folks, Wound Care Karen here. I do want to warn you, this video contains some graphic images of wounds that might not be appropriate for all audiences. This video is really intended for healthcare students and healthcare professionals. Today we're going to talk about wound types and assessment. I'm Wound Care Karen, and I wasn't born in Texas. I got here as fast as I could. I have a passion for wound care and I love sharing my knowledge. Let's simply start with a definition. What is a wound? A wound is any injury to living tissue. It might be caused by a cut, even a surgical cut, a fall, trauma, any type of accident or abrasion, or an eruption like an abscess. Now that we've defined it, let's look at different types of wounds. But first, let's see what you know already. Can you guess what kind of wounds all three of these pictures depict? If you guess pressure ulcer, you're correct. Also known as pressure injury, decubitus, and my mom called them bed sores. Now, how do pressure sores happen? Well, here's a great cross-section of tissue. You can see bone here, soft tissue, blood vessels. This looks like some adipose tissue or fat. More blood vessels, and then different layers of skin. Now let's take this cross section and let's put this patient on a very hard surface, like an old mattress. The weight of their body causes the bone to press against the hard surface, and it pinches off the blood vessels. Look at this. These blood vessels can't flow anymore. They're getting impinged. That causes the tissue beneath it to die off. It starts at the skin level, and then depending on how long the patient is in one position at one time, it might go into subcutaneous and maybe all the way to the bone. Pressure sores are caused from pressure. They can also be caused from friction against this hard surface or shearing. Do you have any idea what type of wounds these three pictures depict? If you guess venous ulcer, you'd be correct. Also known as venous insufficiency, venous stasis, and venous hypertension. Venous ulcers are caused by a pooling of blood in the legs. It causes increased pressure in the veins. There's multiple risk factors, including occupations that stand for long periods. So pay attention, nurses, teachers, cops, factory workers, surgical staff, anyone who stands for long periods are at very high risk of venous stasis disease. So make sure you're wearing your support hose. Symptoms of venous stasis include leg swelling, we also call this edema, cramping, pain. Sometimes you see this brownish staining or dark purple staining. That's called hemosiderin staining. Itchy skin, and sometimes ulcers. Now you see this region right above the ankle and below the knee? That's called the gator region, and that's very often where venous ulcers occur. Now let's look at arterial ulcers, also known as ischemic ulcers. These very often occur on bony prominences. See here on the toes, top of the foot. This is an ankle. Here's another foot. All caused from poor arterial blood flow. Any idea what type of wounds these are? Sorry, that's a trick question. I didn't tell you the patient's history. All of these patients have diabetes. You guessed it, these are diabetic ulcers, sometimes known as neuropathic ulcers. Diabetic ulcers happen because of a multitude of reasons, all combined together. Poor circulation, usually arterial, but also venous sometimes, plus nerve damage, also known as neuropathy. And then neuropathy often causes foot deformities like hammer toes and fallen arches. So all of these things combined with high blood sugars, and you've got the perfect storm for creating diabetic ulcers and then making them very difficult to heal. Let's look at surgical incisions. I'd like to make a very clear distinction between incisions and wounds. Incisions are held together nicely with sutures or staples or glue. And you see how the skin is nice and closed together, well approximated. This incision will go on to heal nicely. However, if any part of it opened, like this did, we call that dehiscence, now it's become a wound and it gets treated very differently. So there's a big distinction between incisions and wounds. Now let's briefly look at some other types of wounds. Sometimes we see some burns in our wound clinic, usually thermal burns, but occasionally chemical burns. Sometimes we see trauma. These are stab wounds. We see a lot of abscesses. Sometimes we see something called pyoderma gangrenosum. That's a big word, so let's break it down. Pyo means purulence. That's the medical term for pus. Derma, of course, means skin. And gangrenosum, you see the word gangrene in there. So when you put it all together, you have purulent skin that has died off. That's a perfect description of this wound. Very, very painful. Bullous pemphigoid usually presents as different blisters and eruptions, usually over a large surface area. It's usually treated with steroids. Hidradenitis suppurativa. I know it sounds like a Harry Potter spell, right? We shorten it and call it HS. It presents as boils or pimples, usually in the armpits and groin, sometimes in the back of the neck. It can be very painful. It is very disfiguring, and sometimes the patients are embarrassed by this, but they really shouldn't be. This is an autoimmune disorder, and so it's treated with immune modulators, sometimes injectable steroids, moist wound care, and the cure for it is surgery. A plastic surgeon can come along and resect this area. If it's large, they can put a skin graft over it, or if it's small enough, they can just make an incision. And that's the cure for HS. Sometimes we see malignancies. Sometimes it's skin cancer itself, or sometimes it's tumors that erupt through the skin, such as this breast cancer here. Animal bites, we occasionally see those, usually because they get infected. Calciphylaxis, this is pretty rare. It can happen in patients with end-stage renal disease, especially if they don't take their phosphate binders. Their hormones and electrolytes just really get off balance, and the skin and tissues just die off. It's very, very painful, very difficult to treat. It very often requires surgery, and it also requires medication to correct their hormonal and electrolyte imbalances. Now that we've looked at types of wounds, now let's move on to wound assessment and then documentation. The first thing you want to assess when you look at a wound is its location. If you can use the medical term, that'd be great. Then you get the measurement. You want to measure the longest length, the widest width, and the deepest depth of the wound. Most measurements are in centimeters. That's what Medicare and Medicaid recognize, as well as most private insurances, centimeters. Occasionally a wound will have some tunneling or undermining. That's when you can stick a cotton tip applicator under the edge there. And so you'll want to measure those also. Then you describe the wound bed. You're simply saying what you see. Do you see granulation? This is new wound tissue, and it very often appears red or moist. Sometimes it's pink or pale. Do you see anything yellow, gray, or tan? That might be slough. Do you see anything black or brown? That might be eschar. The difference between eschar and a scab. Eschar is dead tissue. It's skin or subcutaneous tissue that is dead. A scab, on the other hand, is simply dried blood or a dried blood clot. Then you want to note if you see any exposed structures. Do you see any bone, muscle? You can tell muscle because it has striated fibers. It's pretty cool. You see any adipose tissue? That's the medical term for fat. It's usually yellow and lumpy. Do you see any tendons or ligaments? These are usually white and they kind of look like a violin bow. They have long, hairy fibers. You see any hardware that usually looks metallic? You see any sutures or surgical clips? And then you move on to describe the wound edges. Are they flat and attached, or are they rolled? The medical term for rolled edges is epiboly, and it's wound care Karen's favorite word in wound care, epiboly. I like saying it, and I like spelling it. Are the edges not attached? Are they callous? Then you will go on to describe wound drainage, odor, and surrounding skin. What do you see and what do you smell? Talking about drainage, first you want to note the amount, and then is it clear or cloudy? If it's thick and cloudy, it might be purulent. That's the medical term for pus. We don't say pus in medicine, and we never describe something as pussy. Then you describe the color of the drainage. Is it clear and straw colored? That's called serous. Is it yellow or green? Is it red or reddish peach? The medical term for that is serosanguinous. Or is it bright red or bloody? That's sanguinous. Next, you describe the odor, but it's very important to describe odor after you have cleaned the wound. Most wound dressings have an odor, especially dressings that are kept on for several days, such as hydrocolloids and negative pressure wound therapy. So don't describe that odor. You want to clean the wound, throw away the old dressing, and then note if there's an odor. Is it mild or strong, sweet or foul? And then you want to describe the surrounding skin. Did it get too wet so it looks white? That's called macerated. Is it dry and flaky? Is there callus? Is it denuded? This is the medical term that looks like a diaper rash. So it's very often wet or weepy. It's usually red or dark pink. It's very often tender. That's denuded skin. Excoriated skin, on the other hand, usually looks like little scabbed lines because it's from the patient scratching. So it just looks like little dots from them scratching. That's excoriated skin. Is the surrounding skin red or hot? That might mean inflammation. Or is it indurated? That's another sign of inflammation. Indurated means hard skin. You know, skin and soft tissues are usually soft. So if you notice induration, you want to note that. So in our wound assessment, we've talked about types of wound, location, we measure it, including tunneling or undermining. Then we describe the wound bed, the edges, drainage, odor, surrounding skin, and then of course you want to ask the patient if there's any pain or is it tender. So now let's take what we learned. Let's have a little practice here. Here's a picture from before. What type of wound is this? That's right, it's a pressure ulcer. And I took it one step further and staged it. It's actually unstageable. What's its location? Well, hypothetically, this is on the right posterior heel. Posterior means back of the body. And then we measure it, length, width, and depth. And then you describe the wound bed. Simply describe what you're looking at. So for example, I'm saying that this is covered with 99% dried black and brown eschar, yellow slough on some edges. And then we talk about the edges. They're flat and intact. Drainage, I usually notice that on the dressing that I take off. Odor, there was no odor on this wound, again, after I cleaned it. You can talk about surrounding skin, and always ask the patient if there's any pain or tenderness. Awesome, guys. You did great. You did a wound assessment. Thank you so much for joining me. I hope you learned a little bit today. I certainly had fun presenting. And I hope you'll join me next time when we talk about the 4 stages of wound healing and essential factors of wound healing. Bye for now.